Well, I've never heard a talk that so undermined my subsequent talk, because Sarah's obviously made a migraine treatment plan and, has just shown you exactly what you should be doing. But I'll do the best I can. And thank you, Sarah. So first of all, my disclosures. They're kind of the usual for a doctor in my position who does research and serves on advisory boards and occasionally speaks. But there is a new one, which is I am, and this is important here because I am now the medical co-director or co-medical director, I kind of forget which one I am, of Control M Health, which is a new company that is, all about making a migraine treatment plan, not the medications and the and the devices that I'll be talking about, but all the other parts that don't involve a doctor. So this is what I'm not going to say very much about. Your diagnosis. It's migraine. Calendaring is important sometimes, maybe most of the time. That's a little controversial. There are, good calendars and bad calendars and busy calendars and simple calendars. Sometimes you should probably calendar, but sometimes it's just too much, makes you feel worse, and don't do it. And triggers. I think we need to be really careful about triggers, and how much trigger management you put in your plan. It's easy to get faked out by triggers. Sometimes the feeling you have that you think is a trigger is actually a part of the migraine and not a real trigger. And so I've seen so many of my migraine patients who won't do that, who won't eat that, who can't, can't bring themselves to do a whole host of things that are unnecessarily impoverishing their life. If you're like cutting everything fun and that you enjoy out of your life and you're still having chronic migraine, and it's not any better, really, rethink this process of taking all the delicious and fun stuff out of your life. Migraine takes enough out. So first of all, do think about from diagnosis, is it migraine or migraine plus? There are things that can go along with migraine and can make it worse that we should try to control. We may not be able to do that, but these are some of the things that, if you can make them better, your migraine will get better, although they are not migraine. So if you're using abortives on too many days, that's rebound headache, that's worsening the migraine, that's something that we can often control. If you have inflammation, if you have a dental abscess or a rheumatologic condition, that's going to make, or COVID, that's going to make your migraine worse. Other pain, is, and there's probably a gradient. So, toe pain is less likely to worsen migraine pain than high cervical neck pain. Or jaw pain, those are not the cause of migraine, but the things that are, sometimes fixable and helpful to managing the underlying, the associated migraine disease. Anxiety, depression, those make migraine worse. Obesity, insomnia, snoring, and sleep apnea are often fixable things that will help manage the migraine indirectly. And then there's sort of the rest of the plan, which I think of, with medications, that's the top row. And with, the non-medication, which is the bottom row. And I think someone with a severe migraine problem, disease, should be in an exploring each of these boxes and should just look at, we're going to tweak things. It's just going to be a constant process of perfecting and exploring treatments for each box. Now, I did give my disclosure about Control M, and this is the slide where it comes into play. We've spent a couple of years thinking carefully about what things can people do and how to organize the things that that one does when one has significant migraine disease, outside of medications, devices, and things that need a doctor's prescription. There are core health management tools: hydration, nutrition, getting proper sleep, movement. This is so important. And this is not running a 10K for miles for migraine. This is, remembering to stand up from a Zoom meeting, that if you don't move your body, everything is going to hurt a little bit more. And, that's going to feed back into the migraine and make it worse. It's setting a timer to do a little stretching. When under COVID, when I sit home and spend a full day, 9 hours sitting in front of my computer talking to patients, I get 6,000 less steps automatically. And that makes a difference, and that makes me feel less well and makes my migraine worse. Connectedness, engaging with people, work, play, and relationships. And I think Sarah has shared, exactly how to do that. Self-efficacy, which is confidence and ability to achieve goals. Self-regulate, support, mastery, and observing success of others. And this is the one that I didn't really think about in the right way before this process. And I learned this from people involved in Control M, is growth. Life is growth, and change. And that can be so important, in the life of someone with a chronic illness, particularly chronic migraine. And, I think that this is a tremendously important and under-recognized part of the process of creating a migraine healthy lifestyle. So I wanted to talk about stigma. Those who have migraine, if you're my patient, I've tried to teach you a little bit about this probably, or if not, I apologize, I should have. But to me, I don't think I recognized stigma very much 15 years ago. And then I started to study, and it is everywhere, and it's pervasive, and it soaks the world of headache medicine and the life of people with headache. And it's terrible. It's terrible for the quality of life and the health of my patients. And there are three kinds of stigma. Interpersonal, these are the microaggressions that we hear in our day-to-day, like, migraine can't cause disability, or, I take aspirin and Tylenol together and it's great. Those things, the structural ones. It is so hard to get, let's say, disability, because the laws and policies are aligned against people with migraine. It's so hard to get an accommodation from work, to give people with migraine the flexibility that they need in their schedule so they can be successful and be the amazing people that they are. And then the worst of these, the most toxic of the stigmas in my opinion is self-stigma that is the almost inevitable result of this constant barrage of a lifetime of belittling comments and rules that are aligned against you. And those lead to low self-esteem, depression, anxiety. There's evidence that stigma itself directly damages the pain management system, your internal system of pain, and leads to more pain. It leads to concealment of the disease. It leads to being in a place you shouldn't be because you're having migraine, and being present but not being well and not performing. And it leads to low participation rates in things like Miles for Migraine and lots of other things that can help set that. And in my opinion, advocacy is the greatest stigma buster of all. And here's some of the things that people can do. Tell your story. Telling this, we are the anecdotes we say, and if you tell your migraine story in a less than optimal way, you're not taking the opportunity to frame the disease for others, and you don't have to portray migraine as making you a victim, because as Sarah showed you, it also makes you strong, and tell that story as much as you tell the other one. Use language, like embedded in language about migraine are all these belittling and disempowering concepts. The Coalition for Headache and Migraine Patients has thought a lot about it, and we should be selecting words we use in order to change, to subtly refrain and to push back against the negative framing that's out there in the community. There's one tiny little one that is so subtle that maybe people don't realize it, but it's not impossible. It takes me years, and I still, a stigmatizing or an incorrect word slips in, even for me, who's been involved in this process for, 5 or 6 years. Say migraine, not migraines. Just drop the S. We don't say asthmas. We say asthma. You have a chronic condition, and we have migraine attacks. And that little thing, if we get people to change, will make a difference. Be seen, come out, do it well, seek advice on how to do it. I learned that the mental health community, has a whole process of counseling people, how to come out at work, how to come out about your mental health problems to your family members or to your friends. And they'll guide you through that process. We need to learn as migraine patients how to do it well. Insist on accommodations. This is just important as a ramp for someone with a wheelchair, that you get flexibility at work, that you get the ability to control the lighting, whatever you need to perform well in your life. Support others with your disease and participate in the movement. A social movement is the only thing that's going to change our lives and bring things, bring fairness and equity and new treatments for people with migraine. And by being here, you are a part of that movement. So let's go on to, I'm a doctor and I do things with prescriptions and so forth. So let's talk about that part of treatment. So here are there's acute treatment. Remember the box up there on the left. We're going to talk about that. Recognize triggers and mitigate them. Treat the migraine early. if there's nausea or bloating, you're probably not going to absorb the pill very well. So you may need to bypass the stomach. I can't believe how many doctors forget that thing. Oh, my patient's vomiting and I gave them a pill for sumatriptan. Yeah, right. So think about that. There's nasal sprays, there's, suppositories, injections. Don't use the stomach if it doesn't process medications. Use things that aren't pills, that aren't chemicals. Quiet rest, cold compresses, relaxation, biofeedback, meditation, devices. Use but don't overuse acute medications. Stratify the care. And consider everything else that you have medically, and not when you're choosing your acute migraine treatment. So there are non-specific medicines like NSAIDs, which is Motrin, ibuprofen, Advil, combination analgesics that contain caffeine like Excedrin, the nausea medicines, steroids, opioids, those work for anything. And then there's specific medicines that are for migraine. And those include ergotamine, which we don't use very much anymore, and DHE. There's 7 triptans, there are 2 Japants and more to come. And there is 1 ditan, which we'll talk about. And think about the sort of layers of treatment. As an initial treatment, and then if it doesn't work, a backup, and maybe even a rescue treatment. So, many people need a couple of layers of acute treatment. And then this is how I organize the acute treatments. So there are 4 columns now. The last time I gave this talk, there were 3. And there are triptans, ergots, and the ditans, and that's in column 1. There's 7 triptans, the DHE ergotamine, and the new medicine is lasmiditan or REBOUND. It may be all of the ones in column A you can mix with column B, C, or D, but you shouldn't take 2 triptans for the same headache, or DHE and a triptan. I'm not sure about lasmiditan and a triptan, so I put it in this column. And I didn't want to put 5 columns because that'd be really hard to read. Then there are the NSAIDs. Those are effective for many people, helpful. And when, things are bad, you can mix them with column, from column B, you can mix it with column A and column C or D. They're the dopamine, those are mostly nausea medicines. I'm going to use the other name, the first name, not the generic name, the brand name. So Compazine, Reglan, Phenergan, Thorazine, Haldol, Zyprexa, those are things we use that work through dopamine and can be mixed with anything in the other columns. And the 2 new ones are the ubrogepant and rimegepant, which are Ubrelvy and Nurtec. And so that's sort of the structure that would for choosing your abortive plan. And then there are things that are problematic, which are highly likely to cause rebound for many people. The opioids and the butalbital compounds like Fioricet or Eschic. And those can be used, but should be very carefully monitored and so forth, and are generally not first choice or second choice. Now moving on to preventives. When do you use a preventive? And there are lots of reasons to use a preventive, but one of them, I just wanted to show you some data about what's the risk of going on to having high frequency or chronic migraine if you have episodic migraine. So 52 is 4 per month. We generally talk in 4 per month, 100. I mean, is 4 headaches a month, and 104 is 8 headaches a month, or a little bit more. And the curves start to change around 4, and your risk of having next year chronic migraine, if you have 1 migraine a week, that risk changes around that point, and of going on to high frequency migraine from low frequency migraine changes around once a week. And then when you get to twice a week, the risk becomes very high that you'll progress to worse migraine. So generally, that's where the idea of using a preventive in someone who's having 4 to 8 migraine headaches per month comes from. So you consider prevention when migraine interferes with the daily routine despite acute treatment, when the frequency is more than once a week and definitely more than twice a week, as I just showed you, when the acute medicines are becoming ineffective or they're dangerous because you've got some other problem, your triptan was working well, but now you have heart disease, for example. Some patients just want to control their migraine more completely. I'd heard the story yesterday of a surgeon with 2 migraine attacks per month, but could not operate. And so that surgeon went on a preventive for 2 migraine attacks per month so that he didn't have to cancel, a patient and, 20 people who assist him in the ER, if he had a migraine attack on a surgery day, and people who have stroke-like attacks. There is something in between acute and preventive, which we call bridges. And when somebody's in a bad way, we'll use a bridge. Generally, it's about 3 to 7 days. And the idea is to take somebody from a daily headache to no headache or less severe daily headache, or just break out of the bad cycle. And here's an example of a bad headache calendar with headache attacks on almost headaches every day, some very severe. And then the patient goes into a really bad spell and takes abortives 4 days in a row, calls the doctor and gets a bridge. The bridge brings down the headache severity, very significant over about 2 to 3 days. And these are some of the medicines you can use, or you can be prescribed as bridge medicines. For some people, they may need inpatient treatment or infusion treatment. And the infusion center allows for less disruption to the patient, is less expensive, and you need less infrastructure to deliver an infusion center. You don't need a full team and nurses who are as experienced. And then inpatient is much more serious, much more effective, I think, for people with severe chronic migraine, with severe medication overuse, allows for a more graded delivery. When you're in the infusion center, we only have about 4 or 5 hours to get the medicine in you, and sometimes we get it right, sometimes a little too much or a little too little. Whereas in the hospital, you can just increase each, every 8 hours, make adjustments, stop, change, much more attention to the management. And we can get consults from psychology or psychiatry or, consultants from other parts, and help to make a more comprehensive treatment plan. So there are advantages to both, and they may have a role in your treatment plan. Preventives, just to sort of, again, just paint the background. There's several classes of preventives. Most antidepressants are not migraine preventives, but these four are. Blood pressure medicines. There are 5 beta blockers that we use. That's one type of blood pressure medicine. And then there are 2 other medicines, lisinopril and candesartan, that are effective migraine preventives. Many people, many doctors, I think, are kind of unaware of these 2 ACEs and ARBs. For us in headache medicine, what your blood pressure is has nothing to do with your migraine control. And if somebody has high blood pressure in my office, it's kind of an opportunity. I can, I can help 2 things. I know they'll be able to tolerate this. Whereas if you have normal blood pressure, dropping the blood pressure too much is a side effect. And we may try it, but you'll be more prone to the side effect of low blood pressure. And then the seizure medicines that work, most of them are not helpful for migraine, but these 2 are. Botulinum toxin is for chronic migraine. There are now 4 monoclonal antibodies. This isn't a CGRP talk, but those are available right now, and they've had done amazing things for hundreds of thousands of migraine patients in this country, and probably thousands of migraine patients at the Jefferson Headache Center, and a few ones that are a little bit strange and but have been noticed to be helpful. Memantine Namendus for Alzheimer's, and cyproheptadine is an antihistamine, also called periactin. So those are those are most of the preventive, the pills and the monoclonal antibodies. We may get some GPANs that will be available as preventives in a year or 2, but this is not a talk about the future, but what's available now. And then there are natural preventives. So these include Butterbur. For Butterbur, the branded Petadolix is the one that we're most comfortable about not having the pyrrolizidine derivatives that about 5% of plants can have in them that can be toxic to the liver. So it's important, if you take Butterbur, that you are pretty confident or very confident that there are no pyrrolizidine derivatives. But that's probably the single most effective of the natural preventives. B2 or riboflavin is effective. Magnesium is part of the Control M process. We thought a lot about magnesium. Jefferson, we've changed our recommendations as a result of the process. We're now recommending magnesium malate or magnesium glycinate because they're better absorbed, easier on the stomach, less GI side effects. Feverfew is an old one. It's probably effective, but takes a significant dose and has drug interactions. So if you take a lot of other medications, you should be a little bit careful. Coenzyme Q, melatonin, if you have a sleep insomnia, melatonin. It's really, rarely do we go up above 5 milligrams these days. And medical marijuana, that's a whole other topic. It does help some people the in the preventive world, we generally recommend probably a baseline that is mostly CBD with THC as needed. But one of the problems with medical marijuana is, everybody responds differently. There's no consensus about how to do it and use it for migraine. And my general impression is it's more effective for many of the other things that people with migraine have, the other pain, the sleep disturbance, and only helps a few people for the migraine part of whatever it is that they have. And then there are now 4, and unfortunately, a few weeks ago, I would have been able to have 5 devices here, but the company that made the Spring TMS device has gone bankrupt, unfortunately. That was the magnetic stimulator. That was helping some of my patients. I'm a little disturbed that it's gone. But just there's the cephaly device, there's the vagal nerve stimulator. The gentleman is stimulating his vagal nerve to treat an acute migraine attack. The Nerivio device is another peripheral stimulator. It's completely different in the type of nerve and which pain control system it's stimulating to treat migraine. So the cephaly device on the left stimulates one kind of fiber. It helps some people, maybe doesn't help some others. This to modulate the pain control system that it is trying to influence, you need to be as close to the pain as possible. So, that's the same principle of the implanted occipital nerve stimulators and so forth. Whereas the device on the right, the remote electrical neurostimulator, the REN device, also called Nerivio, stimulates a completely different type of fiber, activates a different pain control system, and it should not be, if you have arm pain, choose the non-pain, don't wear it on that arm, wear it on the other arm. It worsens local pain, or could, but it generally suppresses pain everywhere else. And then there's another way to reach into the nervous system that it can be helpful in reducing migraine pain, which is light. So with the 3 devices I talked about, you're reaching in with the sensory system. With the green light, you're reaching in with the only bandwidth of light that for most people makes the pain a little bit better. And every other wavelength of light, red, yellow, white light, if you have migraine, very well, that makes it worse. And the other thing, if you're have a light or you're contemplating getting one, low intensity. So get the, for many people, putting the green light on really bright is actually making it a little bit worse. You'll get the best results at a sort of low intensity of the green light if you're a responder to green light. So that is sort of the overall big picture. I talked about, triggers. I talked about stigma is something that we can control, and that advocacy, is the best antidote to stigma, in my opinion. I talked about, identifying other conditions and trying to manage them, other pain, inflammation, et cetera, creating other elements of creating a healthy lifestyle for someone with migraine. I talked about abortive treatments, avoiding rebound, a layered plan, bridge treatment, infusion center, hospitalization. I talked about preventive treatments and devices. We have a lot of things available now. If I gave this talk 30 years ago when I came into headache medicine, it would have been, we were in kindergarten then, where maybe we're in high school now. Hopefully the disease will progress and we'll become even more knowledgeable than we are right now. So thank you very, very much, everybody. Miles for Migraine is great, and Sarah Ogden is amazing.